Hi, hello, good morning to everyone, and welcome to the session in Pediatric Ophthalmology and Strabismus at this joint APAO AIOS meeting. We are very fortunate that this has been one of the most successful APAOs, and the AIOS president just told us today morning that the attendance has been more than 12,000 delegates. So thank you very much for your participation and contribution. So the session today, the topic is what not to miss in pediatric refractive errors and seemingly common strabismus. My co-chairs here are Professor Engor Wang, he's from Taiwan, Dr. Meenakshi Swaminathan, she's our local chair and coordinator, she's from India, from Chennai, and I am Sonal Farzavandi, I'm from Singapore. Now, why did we select this theme is because we all routinely manage pediatric refractive errors and prescribe glasses and keep seeing common strabismus daily in our practice. But often in these situations, if we are not really aware of the red flags, we may sometimes miss certain sight-threatening conditions. And hence the aim of this session is to share with our team and our group here some red flags which we should be aware of in our daily practice. To start off with, our first speaker will be Professor Miho Sato. She is from Japan, and she is going to talk to us on does smartphone use induce strabismus? Thank you.
Thank you, Sonal, and thank you very much for inviting me to this wonderful session. My name is Miho Sato. My topic is does smartphone use induce strabismus? There is no conflict of interest. Acute acquired comitant esotropia is a rare strabismus of sudden onset. This graph shows the number of articles published per year using PubMed search with the terms of acute acquired comitant esotropia and smartphone. The number increased significantly after 2016, and it increased even more after the COVID-19 pandemic period. The first report mentioning the relationship between smartphone overuse and esotropia was published in 2016. And during the COVID-19 pandemic period, the incidence of ASCE increased. Therefore, the relationship between excess use of digital devices and ASCE was suspected. But there are some questions that need to be answered. How do smartphones affect our eyes? Who is likely to develop strabismus when using a smartphone excessively? Is it reversible or not? Most studies on ASE are retrospective, so the onset of esotropia is vague. Then we started a multi-center prospective registry study nationwide. The study is to register the patient with acute onset of esotropia, teach them how to use the digital device, and re-examine their eye status 3 months later. Subject: patients are between 5 and 35 years old, and esotropia started within 1 year of their first visit. Exclusion criteria as follows. Method: we asked questions about digital device-related lifestyles and strabismus onset. We measured best corrected visual acuity, refraction under cycloplegia, stereo acuity, alternate prism cover test at near and at distance. The spectacles were prescribed both for hyperopia and for myopia. Then the following instruction was given. Reduce screen time less than 60 minutes a day for younger than 12 years old, less than 120 minutes a day for 12 years old or older, and keep the viewing distance longer than 30 centimeters. Take a 5-minute break after every 30 minutes. Result: data was collected from November 2019 to December 2021. 218 cases were enrolled and 194 cases were analyzed. This is the age distribution. We classified them into 3 groups as child, adolescent, and young adult. The peak age was 16 years old. Male dominancy was found in all age groups, but it is most significant in adolescent group. Here, the refraction valued by age groups. The patients who were older, the myopia was stronger, especially in young adult group had highly myopic. Here are the strabismus angles. The angle at near was significantly larger in the child group than in the adolescent and the young adult group. Angle at distance was larger in the child group than in the young adult group. In addition, the adolescent and young adult groups showed a significantly larger angle at distance than near. This figure shows the time to visit an ophthalmologist. In the adolescent and young adult group, there were many who visited the ophthalmologist between 6 months to 1 year. So let's look at the result of 3 months later. Patients were divided into DD minus, that is using the digital device less than 60 minutes a day for younger than 12 years old, and less than 120 minutes a day over and equal 12 years old. And DD plus patients are 156 cases, and they use a smartphone or digital devices longer than that. This is the duration of digital device use at the first visit and 3 months later. The duration of DD use decreased significantly in DD plus group, but did not change in DD minus group. This is the strabismus angle at the initial visit and 3 months later. Strabismus angle of DD minus group did not change both at near and distance at 3 months. On the other hand, the angle of strabismus was significantly reduced in patients with DD plus group. However, the amount of angle reduction was clinically small. Then we studied the factors related to the outcome. The DD plus patients were divided into 4 groups based on their strabismus angle and subjective feeling at 3 months. The best result is cure, then improvement, no change, and worsening. 10 patients were cured, 58 improved, 67 did not change, and 21 got worse. Here is the duration of DD use at the first visit, 1 month and 3 months later. Patients in the cure improved, and unchanged groups significantly decreased in their digital device use time, but patients who worsened did not change the duration. Here are other factors relevant to the outcome. A short time from onset clinical visit, a small strabismus angle at distance, and good stare acuity at the initial visit are strongly associated with improvement. From these results, we believe smartphone or other mobile digital devices induce acquired esotropia, but it may not always acute onset of acquired comitant esotropia, but some of them are so-called myopic distant esotropia. Myopic patients usually maintain distance to the digital device when they wear optical corrections, but when they do not wear them, the distance to the digital device becomes quite short, and excessive convergence is required. In order to prevent both myopia progression and esotropia, keeping the distance to the digital device and taking a break while looking at the digital device are recommended. Here are answers to the question, how do smartphones affect our eyes? It causes myopia progression and excessive convergence. Who is likely to develop strabismus when using a smartphone excessively? Adolescents and boys. Is it really reversible or not? Rarely reversible. Take-home messages. Wearing appropriate optical corrections is mandatory. Once acquired esotropia occurs, early intervention is required. Lifestyle changes may be necessary. Thank you for your attention.
Thank you, Miho. We will leave the discussion at the end of this session. And so the second speaker would be Dr. Yaoling Liu from Taiwan, and his topic would be, do atropine eye drops cause progression of exotropia in children? Dr. Liu, please.
We'll be discussing at the end of the session. So please reserve your questions, collect your questions for discussion at the end of the session.
Sure, if you have a question while he's setting up, yes, we could.
You see, the thing is that I do a little bit of ophthalmology. This is now called as a mobile laptop syndrome. It happened during the period of the COVID, when the children were not going to the school.
Could you speak into the mic so everybody could hear?
It's not working.
Can you help with the mic? Excuse me.
Not working. Okay. It happened during the period of the COVID when the children were not going to schools, and then they were going to this mobile phones, playing the mobile game. It's not only a question of skin. They would complain of eye ache, headache, eye strain, change in the behavior, depression, vertigo, fainting, abdominal pain, even sleeping with the mobile phones, and then even epileptic-like attacks, autism, and delayed menstrual reporting. Later on, they would get what's called as ophthalmoplegia diplopascate. I saw a case of a twin, 7 years old. They were twin. One twin was a gentle twin. He was not playing the games. The other twin had a esotropia of about 20 to 25 degrees. When I screened him, I gave him -2 cylinder, Axis 120. After using it, it disappeared. So the take-home advantage is parents should not encourage these children, the kids, to the mobile games play. Encourage them to play outside games. Now the thing is that the thing has reduced after the COVID and they're going to school.
I agree.
Yes, thank you very much.
Thank you. Dr. Liu, please.
Okay. Good morning, everyone. It's my honor to be invited here. Today, I would like to explore an interesting question. Do atropine eye drops cause progression of exotropia in children? Intermittent XT or IXT and myopia commonly coexist. The prevalence of IXT is approximately 1% in the United States and about 4% in East Asia. Meanwhile, the prevalence of childhood myopia continues to rise and had reached epidemic levels in certain East Asian countries, including Taiwan. The coexistence of these two conditions are not merely due to their high prevalence. Population-based studies have suggested that IXT and myopia may serve as risk factors for each other. In other words, they are not only frequently occur together, but also they have mutual influence on their development. For children with IST, the treatment options, there are several treatment options available. For those who have good control in their exotropia, observation is a reasonable approach, as deterioration in 1 to 2 years is uncommon. Other treatment choices including part-time patching and over-minor spectacle, which aim to improve XT control. However, their effects are often transient. When it comes to myopia control, there are now multiple treatment options available. For children with both IXT and myopia, spectacles or contact lenses are beneficial as they correct refractive error, provide clear vision, and help in children's XT control. But what about atropine? The use of atropine may have conflicting effect in XT. On one hand, atropine reduces accommodative amplitude and require great effort in accommodation, which in turn enhance accommodative convergence. This may potentially improve XT condition. On the other hand, atropine induces blurred images or photophobia, which may disrupt functional convergence and may potentially worsen XT. So, what is the real clinical effect? Is it good, bad, or actually no effect on XT in children? A randomized clinical trial conducted in China, published last year, provide a clear answer to this question. The study compared 0.01% atropine and a placebo in children with XT and myopia. Their findings demonstrated a 1-year efficacy in atropine for myopia control. The study also demonstrated that the deviation magnitude and the XT control score remains stable in children using atropine compared to those receiving a placebo. They even demonstrated an improvement in near deviation magnitude in children treated with atropine. So the key message is 0.01% atropine eye drops are effective and safe in slowing myopia progression without interfering with exotropia conditions. However, this RCT was limited to children with good or fair XT control at baseline, and they use the low-dose atropine, and they have only a 1-year follow-up period. So how about higher concentration and longer use of atropine, which is the real-world setting, especially in certain East Asian countries like Taiwan? In Taiwan, higher dose and longer duration of atropine indeed is commonly used in children for myopia control. In fact, 67% of Taiwanese school children with myopia have been prescribed atropine eye drops, and with a median duration of about 1 year. So this practice raised the concern about the effect of long-term atropine use on XT in children. So therefore, I conducted a long-term retrospective clinical observation at our hospital. We collect data of XT children with IXT, and who have been followed up for at least 1 year before and 2 years after 0.1% atropine use. And the XT condition was compared before and after the atropine use. This study is still ongoing, and I'm here to share the preliminary result of my cases. Okay, for children who did not undergo strabismus surgery, implying that they have fair or stable XT control, I found no significant difference in XT deviation between before and after atropine use. This is the graph of one of the cases. The vertical line represented the time point when the atropine treatment was started, and as you can see, the XT deviation remains stable before and after the atropine use. However, for children who had undergone strabismus surgery, implying that they have poor or unacceptable XT control, I found 2 of 4 cases showed XT deterioration after atropine use. As you can see from this graph, this particular case remained stable after the strabismus surgery. However, it showed deterioration after the initiation of atropine treatment. So in summary, for children with stable and fair XT control, atropine eye drops does not cause XT progression, even in higher dose and longer duration. And this is based according to my limited clinical observation. But however, for children who require strabismus surgery, high-dose atropine eye drops use may be associated with XT progression and should be used with caution. It is important to note that this statement was based on my very limited clinical observation, and the study is still ongoing. Thank you for your attention.
Thank you, Dr. Liu. We allow for one question, if there is any. Yep. Miho, please.
With the orthokeratology, the use of orthotic contact lenses.
No, I haven't those data.
In the Asian countries, the use of atropine availability is okay. But the other modality of this medical treatment of myopia is the orthotic contact lenses.
Yeah.
They are put to the children and they cause during night corneal reshopping and the myopia disappears. And they are also supposed to regress the myopia by about 40%. But the thing is that it's okay in that well-developed countries like USA, UK, because the cost is high,
Yeah.
its use, its complication. can be managed there. But in India and other countries, as you rightly said, the use of atropine is the best outstanding modality of the treatment.
Yeah. Thank you.
Thank you.
Please.
Thank you for the second question. And in our study, we noticed the patient who had anisometropia is more likely to develop
Deterioration.
acquired esotropia, and also the intermittent exotropia patients develop anisometropia so strongly. However, checked the anisometropia after atropine use.
Yeah, this is a good question. So in my clinical observation, we observe a large amount of anisomyopia in children who treated with atropine. So I'm not very sure about the deterioration, the XT deterioration. Is it merely caused by atropine use, or it is caused by their development of anisomyopia? So this analysis will be conducted in our study, and we will do a stratification or adjustment for their myopia progression and the anisomyopia. So maybe we'll give you the clear answer after study. Yeah.
If a child has intermittent exotropia and not much of myopia, but he's not wearing his glasses, not doing exercises which he's told to do, what will happen to the intermittent exotropia? Will it progress or will it remain stable?
Some of them, most of them, if they are presented to you and it shows a low XT control, a higher control score, means that they have a good control for their XT. Studies have shown that if they have baseline good control of their XT, it is uncommon for them to progress in 1 to 2 or 3 years. So you can only just follow up.
Just observe.
Yes.
Okay. Thank you.
Thank you so much, Yaolin. We'll take some more questions because we have saved time for discussion. Thank you. We have colleagues who are standing at the back. We have seats in front. So if they could move in front, there are some few seats available. If the AV team could have the audience who are waiting to come in front. Thank you.
So our third speaker would be Dr. Subhashini Kadapu, and from Australia, and her topic would be tips for glasses prescription in children with strabismus. Okay, Dr. Kadapu, please.
So the podiums are typically alternate, so the next speaker will be speaking from there.
Good morning, everyone. It's a pleasure and a privilege to be here. I thank Sunil and the APO committee for making me a part of this session. So we're going to delve into the very basics of pediatric ophthalmology here, which is prescribing glasses in children and specifically in children with ocular misalignment. We all know that vision testing in children is no easy feat. Children often are very difficult to examine, and the examiner often needs to be very patient, needs to reserve a lot of time, and also need to have quite a bit of experience in measuring vision in children. The vision measurement not only depends on the age, also on child's attention and ability. A very young infant, a child very uncooperative, or a child with developmental disability, you might have to modify your vision testing accordingly. And sometimes all you may get is a fix and follow or a central steady maintained fixation, or even just equal objection to cover. So hence, in children, we still have cycloplegic refraction being the cornerstone of refraction. This is a very age-old technique and it still holds good till today. In Sydney, western part of Sydney where I practice, we are quite multicultural. So the choice of drops depends on predominantly on the color of eyes, and also the percentage of drops depends on the child's weight. If it's less than 10 kilos, you're using lesser concentration of cyclopentolate. So the part with the worst bit of pediatric ophthalmology is the children and the parents hate coming into the clinic. And it's very important for you to inform the parent about the process of the eye drops. And we need to involve them, because otherwise it becomes quite overwhelming for a parent as well. So the drops often needs to be repeated in a dark-eyed child. Incomplete cycloplegia or ocular misalignment often can cause that is probably our everyday practice in pediatrics. So incomplete cycloplegia and ocular misalignment can cause very erroneous readings on refraction. So often the refraction may be over or underestimated if the pupils are not fully dilated, or if the eye is misaligned because you're not in line with your retinoscopy beam is not in line with the pupils. Sometimes we may resort to atropine, especially if you're suspecting accommodative esotropia with high hyperopia. Very occasionally, we resort to examination of the child under anesthetic, and I try to find an opportunity of another general anesthetic procedure to combine my refraction with. So, retinoscopy still is the main tool in the age of AI and automation. We are still not going anywhere without the retinoscope. So once we have had a refraction, you've taken off the working distance, there are many factors to consider before we actually decide to prescribe. And most importantly, the age and the ocular alignment. Symptoms are very minimal in most children with refractive errors when they're very young. So if I put this busy slide, the audience is going to be disinterested, and so will be my registrar in the clinic when I'm trying to tell him what are the guidelines to prescribe. So I usually tell them a very simple rule of thumb. This may vary among clinicians with various expertise in different parts of the world, but this is what I tell them simply. Any hyperopia of more than 4 diopters is worth prescribing. Again, it might vary depending on the child's age. We usually fully correct astigmatism and anisometropia. The only easy thing here is you have to fully correct hypermetropia associated with esotropia. Once I've prescribed the glasses, I again spend another 5-10 minutes with the child and the parent and explaining what type of glasses they need to get. They have multiple questions. They're overwhelmed with the diagnosis of a refractive error. So you need to sit with them and explain that glasses need to be worn full-time, needs to be fitting the child well. The lenses need to be shaved thin if they're high refractive errors, and the vision improvement is not immediate. So the child's going to wear glasses and is going to complain of blurry vision, and it doesn't mean that you've given them wrong glasses. And often you do get calls from the parents about this, or the optometrist telling them that that may not be the correct prescription. So I do spend extra time with the child. Now, we know about the eye growing quickly, achieving emetropia around 6 to 8 years of age, but we know the children are still hyperopic about 6 to 8 years of age, and we often see overprescription of low plus glasses. And this is not usually recommended, but the children are usually presenting with vague symptoms of near blur, headaches, and even learning difficulty get prescribed low prescription glasses, while actually it's not a visual difficulty, it's a learning difficulty that needs to be addressed. The only hyperopia that I prescribe is more than 4 diopters, and I usually undercorrect by a diopter and a half. I usually associate astigmatism and anisometropia is fully corrected. You need to advise the parents that it's going to be a slow progress with vision, and it might take months to years for the vision to improve. The hyperopia slowly diminishes in the late primary school, and they usually tend to prefer less prescription as they get older. Bifocals is very rarely prescribed. I do probably if they're hypoaccommodating, and especially children with trisomy 21. So coming to esotropia associated with hyperopia, we usually fully correct hyperopia of anything over 1.5 diopters. Now, we need to be mindful because there are some accommodative esotropia that can present acutely, and if they're still significantly hyperopic, I treat them as acute accommodative esotropia. But if the hyperopia is not very high, then I have to think about other causes. Need to look for full abduction to see whether the child's well, and may even require imaging in some cases. It's a non-accommodative esotropia. Now, I bring the child back in 3 months just to see how they're wearing the glasses, whether the glasses have been made correctly, and if they're still significantly distant esotropia, and if I'm concerned about undercycloplegia, I would probably do a repeat atrophy and refraction and correct any residual hyperopia if there is. If not, then I'm looking at what their how their vision's going, and if they're micro ET, I'm still monitoring for amblyopia. If they're partially accommodative, again, amblyopia is a factor that we need to monitor, and I do an annual refraction, and then probably office surgery if the esotropia is still significant with the glasses. There's one subset where the esotropia is significant for near, and then I stick on +3 over the current glasses, see whether I improve for near, and I prescribe the bifocals with the near out of +3. It's important to give the advice on your prescription how the near segment needs to be. It needs to be quite a large near segment with the top of the D segment bisecting the pupil. So the natural history for accommodative esotropia, you find that once you refract them again next year, you find that the plus has increased. And this is a natural progression, and you need to advise the parents that it is actually going to increase before it improves. And this discussion is important, otherwise the parents think the whole idea of giving glasses is to make things better, but it's actually gotten worse. You also need to advise that once they start wearing glasses, the esotropia without glasses may be worse, and this is because of less accommodation. So infantile esotropia is also I needed to discuss, because I usually give them +2.5 if their hyperopia is higher. I trial glasses before surgery. Intermittent exotropia will still fully correct myopia. I would fully correct associated astigmatism. I don't prescribe any prisms or low plus glasses, and I undercorrect the hyperopia. Usually they do improve. Over minors, I do them in specific cases. They have a good control for near, and they do maintain their exotropia with their glasses as long as they're wearing them. There is no usual concern about myopic shift. Usually these children are myopic anyway. So I'll leave you these tips on how to manage refractive errors in children. Thank you for your time.
If there's any question? Okay, thank you. And our fourth speaker will be Victoria Balasani. And her topic would be, why not to miss refractive amblyopia? Dr. Balasani, please.
Good morning, dear colleagues. First of all, let me to say thank you for the organization, for the invitation. And today I would like to tell you about what can be hidden behind seemingly ordinary refractive amblyopia and how not to miss the underlying diseases. No conflict of interest. Uncorrected refractive errors are considered the most common cause of amblyopia. According to AIOS, there are two main types of refractive amblyopia, and severity of the refractive error and amblyopia are directly related. Behind the mask of high refractive error and amblyopia, more serious eye diseases can often be hidden, such as congenital eye abnormalities of chorioid, vitreous body and lens, inherited retinal disorders, congenital optic nerve and macular disorders. And it's very important not to miss this condition and the onset of progressive inherited diseases. A comprehensive examination of the patients is essential for an accurate diagnosis of amblyopia. All patients with amblyopia should undergo not only a standard ophthalmological examination, and I'm sure that most doctors will agree that even when we are absolutely sure of the diagnosis of refractive amblyopia, a routine ophthalmological examination is not enough. In our clinical practice, whenever possible, our patients with amblyopia undergo electrophysiological examination and OCT in order not to miss concomitant serious diseases. The use of OCT makes it possible to diagnose diseases that are not visible during a routine examination of the fundus, especially hereditary and congenital diseases in the early stage. Conducting visual evoked potential is necessary to detect it, meridional amblyopia, optic nerve atrophy for an objective assessment of treatment result, and dynamic observation. And so I'm sure, sorry, okay. And dear colleagues, let me show you using several clinical cases as an example why it's so important to carry out additional examination and why the previously mentioned methods are included in the standards of examination of a patient with amblyopia in our clinic. The results of the ophthalmological examination are presented on the slide. You can see hyperopia 10.75, astigmatism more than 2 dioptries. Best corrected visual acuity on the right eye was 20/60, over the left eye was 20/40. Cycloplegic refraction and examination results correlated with the diagnosis of refractive amblyopia. And as you can see on the slide, OCT also showed normal results. But in our clinic, a patient was prescribed glasses and then started pleoptic treatment with permanent alternating occlusion of the right eye and the left eye, of course, taking into account the difference between the visual acuity. And so after one course of treatment, we got the following results. Visual acuity on the right eye increased to 20/40, in the left eye to 20/30, you can see on this slide. And despite the fact that OCT showed normal results, since the patient has high hyperopia with axial length about 19 millimeters, and we know that OCT usually doesn't take into account the influence of the refractive errors, especially of a high degree, on quantitative measurement of fundus structures, we supplemented the previous examination with electrophysiological examination, visual evoked potential, and electroretinography. The results of conducting examination can be viewed on the slide. Visual evoked potential showed only functional signs of slowing down the time of the nerve impulse along the visual pathway, and according to the ERG, signs of pronounced dysfunction of rod photoreceptors were observed in both eyes, as well as moderate suppression of the bioelectric activity of the central parts. Taking into account the results of the electroretinography examination, the patient was recommended to undergo genetic testing to confirm or deny chondrodystrophy. And what we see, genetic testing revealed 2 types of mutation. The first cause is chondrodystrophy type 2. Mutation in the second gene lead to the development of retinitis pigmentosa type 40. Further plan in this case for patients is dynamic observation together with ophthalmogenetics, and as you saw previously, we received good results after vision therapy, so we will continue to treat amblyopic cause of reduced vision. The next patient, 5-year-old boy, was referred to our clinic with diagnosis refractive amblyopia, mixed astigmatism, for vision therapy. Despite the fact that refractive error is quite similar on both eyes, in this case seems like regular refractive amblyopia. But examination shown that best corrected visual acuity of the right eye and the left eye was significantly different. Eye fundus examination of the left eye revealed huge macular chorioretinal oval atrophic lesion. Patient was recommended to undergo OCT and web examination, and what we see, OCT reveals that retina without any visible structural pathology, mostly normal thickness, and on the left eye changed according to the type of chorioidal coloboma. According to web result, in the right eye there are no electrophysiological signs of visual pathway dysfunction were detected. Nevertheless, in the left eye, electrophysiological signs of severe visual pathway dysfunction were found. As the retina of the right eye is preserved, patient was prescribed to undergo vision therapy courses. We also tried to treat left eye. After 3 courses of pleoptic treatment, amblyopia of the right eye was eliminated, and on the left eye we also see good results. We also have reached improvement in the vision, and so the refractive amblyopia took place in this case also. And our last patient, a 12-year-old boy admitted to our clinic with diagnosis of refractive amblyopia, high hyperopia, hyperopic astigmatism. Examination shown that best corrected visual acuity on both eyes was very low. And we conducted fundus exam and OCT of the retina, which shown normal results. Visual evoked potential and electroretinography revealed slight functional change in the optic nerve and retina. And in that case, we decided to start with laser correction of refractive error as the first step of the patient's treatment in order to create optimal conditions for further amblyopia therapy. And after a rehabilitation period, patients started vision therapy courses. So there were 3 10-day courses during 1 year. And at the end, we got high visual acuity result. Amblyopia on the right eye was eliminated. And so for the plan for this patient of treatment to continue vision therapy to treat amblyopia on the left eye. And that's it. So dear colleague, what we want to say, okay, that even we see the refractive error, which should seems to imply the cause of refractive amblyopia, it's important not to conduct the more detailed examination, conduct additional method of examination, which we say, and refractive anomaly also plays role in visual function, and we should not refuse to treat amblyopia, since even we with serious underlying condition, there is still a chance to increase visual acuity and improve the patient quality of the life. Dear colleagues, thank you for your attention.
Thank you, Dr. Balasanyan. Next up, we have Dr. Wei Yan, who is going to be speaking on when is a seemingly common esotropia dangerous, and why he is connecting. We can take a question or 2 for the previous speakers, and please use the mic.
Now, at the mic, please, at the mic. The second case which she illustrated almost had a similar refractive error in both eyes, and there was a fundus abnormality in the left eye, yes, isn't it? In that case, when you have similar refractive error in both eyes, and one eye has good vision and the other eye has poor vision, you cannot name it as refractive amblyopia. Refractive amblyopia, there is either anisometropia or both eyes are affected with an almost similar kind of refractive error. Second case.
But vision acuity was also different on this side. Maybe it wasn't a very...
But the refractive error was the same, isn't it?
The refractive error was the same.
That's why I say that there could be an organic problem like a retinal issue.
And what we showed that on the left eye, the patient has chorioretinal coloboma, and that is why in this case, we want to show that even we have underlying diseases, we should continue to treatment for improving the visual acuity. The refractive error was similar, you are right, but on the that is why after the treatment on the right eye, the amblyopia was
the right eye was not amblyopic actually.
After the treatment, but before the treatment it was amblyopia. Maybe
very small amount.
Small amblyopia, yes.
You are.
Yeah. Thank you, Dr. Manjula, and thank you, Dr. Balasanyan. Over to you, please. Thank you.
Thank you. Very good morning to everyone, and I would like to thank the organizing committee for this opportunity to speak. So I'm Dr. Wei Yan Ng from Singapore, and today I'll be speaking on when is a seemingly when is a seemingly common esotropia dangerous. Right, and these are my financial disclosures. So I'd like to present on the case. So this patient on presentation was a 29-year-old male that came into Singapore National Eye Centre a few months ago into our general clinic. And his main presenting complaint was actually that of a 2 weeks worth of a torsional diplopia, which he did not present with or complain previously. And overall, the progression was that it was actually gradually getting worse over the 2 weeks. And he was actually a known patient with previous ocular issues before, and his last review was in 2 years ago, of which he has defaulted. So overall, his medical condition, he has seen multiple hospitals as well as a fragmented medical record. So some background, back in 2008, he had large cell medulloblastoma in his intracranial medulloblastoma, of which he then underwent surgical debulking and chemotherapy. And at that time, an external ventricular drain was inserted, of which he then developed some complications. And subsequently, about 1 year later, due to hydrocephalus, it was then switched into a ventricular peritoneal shunt. And after that, he had no hydrocephalus, and based on his last report, which we have no images because it was done in another hospital, 6 months ago, the last MRI was actually reported as pretty stable, though there was a hint that there was a slight increase in lateral as well as the third ventricle. Right? In terms of the ocular dysfunction, so since the diagnosis, he has been having a chronic left sixth nerve palsy as well as a concomitant LHT that actually developed much later back in 2020, about 5 years ago, just at the start of COVID. And since then, he was on grinding prisms, of which he has actually been coping very well, no torsional diplopia complaints. So this was his examination. Visual acuity was good, and then he had a left esotropia of about 10. That was a bit incomitant, especially worse on the left gaze with a bit of a left hypertropia. And overall, based on that examination then in the general team, there was a slight minimal limitation in abduction of the left eye without any significant vertical overaction or underaction. And at the time, the double Maddox rod showed that there was some degree of excyclotorsion. Right? And crucially, there was no papilloedema when we examined the fundus at the time. And so he was given just a routine follow-up to the pediatric clinic, of which he then postponed, and he came in 2 months later. Right? And this time he complained of increasing torsional diplopia. And this was his examination. Again, visual acuity remains good, 6.7.5, and the esotropia as well as the hypertropia actually remains pretty stable. Less of an incomitance in this visit, but that might be due to a bit of variation. So during my examination, there was actually a little bit of, there's a bit of SO underaction in both eyes, as well as a slight limitation in the abduction of the left eye, with a bit of an inferior oblique overaction. And at that time, the double Maddox rod showed there was an increase in the excyclotorsion, especially in the primary as well as the inferior gaze. And crucially again, there was still no diplopia. So basically this patient has increasing diplopia but not worsening esotropia and no clinical signs at that moment of papilloedema or raised intracranial pressure. And symptomatically no giddiness or headache at that moment. Right, so this is his nine gazes facial photo. He has slight left gaze limitation, as well as a bit of limitation of the superior oblique. So this is the left eye, the adductions of the left eye, of which again there's a bit of limitation of the superior oblique. And this is the night gaze photo of the right eye adductions. And this is the widescreen, of which it showed significant excyclotorsion in both eyes, with and without fusion. And this is the fundal photograph. As you can see, there's no disc swelling, and there is with the line drawn, there is a bit of excyclotorsion present in both eyes. And so in view of the recent changes, I decided it's still better to just, even though there was no increasing esotropia that might accompany the sixth nerve palsy, I decided to schedule a repeat MRI, even though 6 months ago everything was cleared by the neurosurgeon. And then the radiologist calls on a Sunday evening, immediately after the MRI has been done. So this is the video of the magnetic resonance imaging, of which you can see that there is now enlarged ventricles, even though that the VP shunt is in situ. Right, so I just replay it one more time before we move on. Okay. Okay. And so this is the comparison. We had one MRI back in 2017 where he was done in one of our main institutions affiliated with us. So this was the 2017 MRI, and this is the 2024 MRI that was done. And so it shows stable position of the BP shunt, but there was significant hydrocephalus with mass effect as well as effacement of the basal systems. But luckily, no new lesions were seen at the moment. And so in terms of progress, he was then called back urgently and then admitted to neurosurgery, where the shunt was then interrogated by the neurosurgeons. And they found that there was actually no obstruction. Curiously, the pressure was actually normal, and all the other metabolic tests as well as cultures were normal for the CSF. So it was finally determined that this is likely secondary to a shunt malfunction. And review after about 1 to 2 months after that interrogation, where everything was cleared, he came back with improving torsional diplopia. So vision remains stable, 6.5 both sides, as well as a left esotropia and left hypertropia, which again is still relatively stable, though there is a little bit of an improvement on the left gaze this time. And in terms of the overall movement, we do not have a repeat fundus photograph, but there is a reduction in the excyclotorsion in all gazes in the vertical gaze. And again, there was still no papillary edema noted on fundal examination. So in summary, increasing hydrocephalus might not present with papillary edema that we know, but in a patient with a known sixth nerve palsy due to the intracranial lesion, increasing hydrocephalus might not directly affect that sixth nerve, which has already been compromised. And something that if it presents atypically, it should, especially with a history of intracranial lesion or intracranial surgery before, then it's still better to order a scan on the safe side so that we can detect certain atypical presentations like this. All right, and with that, I would like to thank you for your kind attention.
Thank you, Dr. We'll take the questions at the end. The next talk, we invite Dr. Marilyn Hong to speak on when is a seemingly common exotropia dangerous? Another young speaker from Singapore.
Good morning, one and all. I'm Marilyn from Singapore National Eye Centre. Again, I'd like to say thank you for inviting me here. I'm very excited to share with you this case presentation that we have today. So the topic that we are tackling today is when is a seemingly common exotropia dangerous? So the case that we are presenting at hand is that of a 47-year-old Chinese female who presented with left upper eyelid swelling, pain and redness for 1 week duration. She has no history of contact lens wear, and the visual acuity in her right eye is 6.7.5, while that in her left is 6.9. On examination, she was found to have bilateral meibomitis. And this is her clinical photo on the right, showing that of left upper eyelid swelling as well as marked prairie erythema. The rest of her eye examination was normal. So at this point, I'd like to conduct an audience poll. What would you do if you were her treating ophthalmologist? Kindly raise your hands at the option that you would choose. So option A would be you would invert her eyelids. Option B would be you will start her on fusitamig and lid hygiene. And option C, you will start her on oral augmentin. Okay. And who would choose option D, which is oculoplastics consult for preceptor cellulitis? Nobody. Okay, great. So as most of you chose, we treated her initially for preceptor cellulitis, secondary to meibomitis and blepharitis, and she was given oral augmentin, fusitamig, chloramphenicol, and blephagel. So she came back during her second clinic visit, and she said, "Doctor, I feel my eyelid swelling and pain is much less than before." But she also complained of some difficulty in reading, of which she could read N8 clearly unaided in her right eye, but needed +1 diopter sphere to read the same N8 page in the Moorfields bar reading book with her left eye. So on further review of notes from her family physician that we obtained, she was currently being treated for ongoing migraine. And when we elicited further history from this patient, she actually complained of neck pain radiating to her left shoulder for the past few hours. This was accompanied by a left unbearable throbbing headache, which wakes her up from pain. And she also noted, importantly, left eyelid drooping subsequently with no diurnal variation or fatigability. So let's go back to look at her eyelids. The photo on the right, the photo on the left side is actually her photo of her during her first clinical presentation, and the photo on the left is that during her visit. So I'd like you to take a moment and think about whether there's any difference between these two photos. Yes, so I can hear some answers there, very good. So current visit, during the current visit, she was actually told by her initial ophthalmologist to remove her eyelash extensions, and it's become very, very apparent that there's a clear left ptosis involving the visual axis in her current visit. The first visit, she had long, beautiful eyelash extensions, and yeah, now currently, she has this significant left partial ptosis involving the visual axis. So on general inspection, as I've heard from the audience as well, on lifting out of her left eyelid, we notice a right exotropia as well as hypotropia. And these are her clinical photos of her versions in 9 gazes. So of significance, the left eye was limited in up gaze, right gaze, as well as down gaze. So on pupil examination, she was also found to have anisocoria, with the left pupil being larger than the right. This was in the dark. And this was her pupil examination in the light, with the left eye pupil being larger than the right, which is more obvious in the light. And hence our working diagnosis at this point is that of a left third cranial nerve palsy, which is pupil involving, and we sent her immediately to the emergency department for an emergent computed tomography of the brain and angiography of the circle of Willis, which revealed a saccular aneurysm. Sorry, the yellow arrow is a bit displaced downwards, but it revealed a saccular aneurysm of the left posterior communicating artery, seen here, measuring 0.3 by 0.3 cm, and with the neck measuring 0.2. So the patient was subsequently sent for endovascular embolization by our interventional radiologist team, and this was her pre-embolization and post-embolization images, which shows very nicely the photo on the left, the saccular aneurysm of the posterior communicating artery, and the photo of the right showing complete obliteration of the saccular aneurysm post-embolization with good preserved posterior circulation flow. And this is a clinical photo of her post-embolization showing complete recovery of the ptosis as well as the ocular deviation. So we'd like to discuss this case because, importantly, where was the roadblock in the treatment of this patient? So it's our theory that the doctor was initially deceived by her beautiful eyelash extensions. So in summary, when is a seemingly common exotropia dangerous? Firstly, when there's red flags in the history, such as the presence of neurological symptoms, raised intracranial pressure symptoms, such as that of headache, nausea, vomiting, pulsatile tinnitus, diplopia, as transient obscuration of vision. History of preceding trauma is also important to elicit, such as the presence of, and also the presence of previous inflammatory diseases, such as that of systemic lupus erythematosus and other vasculitides, and also importantly, the history of malignancy and any constitutional symptoms. On examination, such as in our patient, if there's presence of ptosis, duction deficits, anisocoria or fatigability, if you're concerned about myasthenia gravis, is also important to take note. And last but not least, when the patient has unaddressed concerns, it's important to address them rather than brush them aside. This is a presentation from the Singapore National Eye Centre, and I'd like to invite all of you guys to join us next year in Singapore as well for the 8th Asia Pacific Glaucoma Congress. It's going to take place from the 24th to 26th of July, and you can scan the QR code here to join. Thank you.
Next up, we have our chairperson, Dr. Sonal Fazavandi, who will be speaking on lessons learned from seemingly common strabismus.
Thank you, Meenakshi, and thank you everyone for staying till the end of this session. So I'm going to close the session with another case of a lesson learned from something which was a very routine strabismus we all see in our day-to-day practice. So as a young gentleman, about 30 years old, he came to us for a V-pattern exotropia, which measured about 45 prism diopters. You can see the V pattern increasing in up gaze compared to the down gaze with some oblique overactions. And then it's a regular kind of a case. He has undergone both eye strabismus surgery. Post-operatively, he did very well. And then we discharged the patient. Patient comes back 15 years later, and he says, now my eyes are drifting again. And this is not uncommon. We often operate patients in their teens, and they come back in adulthood saying, oh, my eyes are drifting again. Vision was good. He tended to prefer the left eye fixation. But once again, the exotropia came back to in the same kind of a magnitude, like nearly 45 prism, like pre-op. That's a little bit not so common. You do get recurrences, but not normally of the same large angles. And patient says he has absolutely no control on this exotropia. So I'm now going to show you a video, and let's see what's going on. Okay, so that's looking right and left. He's looking up. He's looking down. It looks like some inferior oblique here and there. Looks like one of those regular squints which come back. Sorry. So here you are seeing the patient in the 9 positions of gaze with his large angle exotropia fixing with the left eye. If you notice when he's looking to the right and to the left, there's some amount of limitation of adduction in both the eyes. So this patient has had a surgery. It was 15 years ago. I hadn't yet traced the case notes because, you know, I have to go back into the warehouse to find the notes. So let's re-look at this so-called adduction deficit. So we did duction testing. And true enough, you can see here that the right eye adduction is limited. How about the left eye? When you do duction deficit here for the left eye, even the left eye adduction was a bit limited. It's post-operative. Would it be iatrogenic? Quite likely. We can't decide anything until we have the notes. So what's going on? Maybe iatrogenic, maybe not. Did my surgery involve the medial rectus? I couldn't remember. It was a large angle, 45-50 prism. If it did involve the medial rectus, maybe over time, is this a slip muscle? Did I have a loose pole? Is this a long-standing stretch scar in both eyes? Or maybe it's none of the above, and this is really something else. So we found the old case notes. Surgery was done on bilateral lateral recti, recession of 8.5 maximal. Both eyes inferior obliques were anteriorized and they were secured at 1 and 4 mm because there was a small height. But the medial rectus was untouched. So now we go back. Could this be iatrogenic? The answer is no. It's not iatrogenic. I hadn't touched the medial recti in both eyes. So what's going on? Let's re-look at the video. Oh, why is the video not playing? Huh? Yeah. Okay. So look at the right eye. There's adduction deficit and there was a nystagmus. Do you want to see the video again? You can look at that. Look at the right eye. There's an adduction deficit and there's a left abducting nystagmus. Okay. So what do we do now? Look at that. Adduction deficit, right eye, left eye, abducting nystagmus. Everyone's convinced? Yes, it's bilateral. Yeah. Left eye even, but the left eye adduction deficit is not as significant as the right, correct? So we have an adduction lag with an abducting nystagmus, which was really staring at us. And yes, if we really go further, there was the same thing on the contralateral side. So now is this incomitance worrisome? Everyone will unanimously agree this is a red flag. Okay, so we had to get a neuro-ophthalmic consult. You know, they will order all the tests, visual fields, OCT, GC, IPL, everything was normal. Plan was let's do an MRI. And here you are, we have an MRI, T2 weighted images on axial view. They were showing some hyper-intense lesions involving the periventricular white matter. And on further discussion with the neuroradiologist on this T2 flare sagittal view of the MRI, they said that they have these periventricular inflammation, these shadows which are suggestive of perivenular inflammation. This is called Dawson's fingers, and it is a classical sign of demyelination. Well, our patient had actually no other presenting signs except this adduction deficit and an abducting nystagmus, which is, as all of you know, that is known as a internuclear ophthalmoplegia. So we went in and did some further studies on the optic nerve because clinically the nerves look normal. However, on the pattern VEP, there was some small and delayed responses, and there was undetectable responses for the smaller checkers, and hence the patient did have subclinical optic nerve dysfunction in both eyes, which is consistent with a demyelinating condition. ERG, however, was within normal limits. So to end this, what was our lesson learned? Seemingly common strabismus walk in and out of our clinics. We have several patients a month, hundreds, and we treat them just cursory. Sometimes it is just a recurrence of a strabismus, and we try to relist, so better be very careful. Watch duction deficits, because in this case there was an exotropia with ipsilateral adduction deficit and a contralateral abducting nystagmus, right more than left, which is an internuclear ophthalmoplegia. And if we had not paid attention to the duction deficits, we could have easily missed this on a cursory examination. Some references for further reading. And thank you so much for being here. And I would like to close with a warm welcome and an invitation to the 3rd Congress of the Asia Pacific Strabismus and Pediatric Ophthalmology, which will be held conjoint with the Australia and New Zealand Strabismus Society. It is going to be in Brisbane this year in end of June to early July, which is very beautiful weather to come and visit Brisbane and see the koala bears and the kangaroos. Thank you so much.
Thank you, Dr. Fazawandi. Okay, we are open for questions. Request you to use the mics that are available in the aisle. And if you just cannot find yourself, ease yourself out, the mics will arrive to you.
Yeah,
Please
Dr. Swaminathan, I am Vivek here. Yeah, so this is regarding, the motility pattern that you have shown. So there is a right adduction limitation with...
Speak louder.
Yeah, there is a right adduction limitation with left nystagmoid movement. So usually this is a very classic localizing sign. So I would anticipate the lesion in the, the MLF on that side. So this is quite surprising that, there is no lesion in the MLF, and very unlikely that, the paraventricular plaques, probably they would present like this. I think you need to go back and, talk to your radiologist and ask them to have a very specific cut into the, the midbrain and the brainstem. So probably that will help to localize. Otherwise, it's very unlikely that, the right iono would present with a paraventricular lesions.
Thank you so much.
Thank you.
Thank you.
Thank you, Dr. Varkar.
Hello. Hello. Yeah, my question is why not all the hyperopes develop the esotropia, and what are the red flags, what are the things we need to pick up to make sure that the patient won't develop the future esotropia when we'll see mild and moderate kind of hypermetropic patient?
Subhashini, you can answer. Come to the mic.
Yeah, that's a very good question. I think it depends on their accommodative effort. Many of the children, if they're able to maintain their accommodative effort, they say the lesser hyperopic they are, they may develop esotropia, but very high hyperopes, they don't have any accommodative effort, and they usually don't become esotropic. And that's kind of the general thinking, I think. Yeah. But it's hard to know which patient will develop esotropia or not. But generally, accommodative esotropia is present typically about 1.5 years of age, and the hyperopes with reduced vision are often picked up at 4 or so when they have visual difficulty.
My question to panel is, today we are trying to correct the myopia as we are getting the refractive error. So in this era, is over-minus glasses still prevalent, and are we prescribing over-minus glasses? Because now we are saying that we should give optimal correction, whatever refractive correction we are getting on cycloplegia for myopia. So are we still prescribing the over-minus glasses?
Yeah, very good question. I think there is a lot of debate a few years ago with a paper where they had a concern that these children had progressive myopia with overcorrection. I think that's kind of disproved. I think these patients are generally tend to become myopic anyway. I agree with the fact that we need to give them the full correction, but I only have a very small subset of patients who are actually slightly hyperopic that I prescribe over minus, meaning say their refraction is +2, I give a -1. And these are usually preschool children they're not in school, they're not doing much reading activities, and I only give it as a buying time before we decide whether they're going ahead with surgery or whether they're getting better and controlling better, and the parents are still in the middle of we want something to be done, you just don't want to watch them. So those are the subset of children I give over minus, not every child. Yeah, and usually there are reports they're maintaining good control with these glasses, but the treatment is usually temporary.
Yeah. Doctor, do you practice in India? I will tell you the Indian perspective. Our children start school at 3. Okay, so the over minus glasses have to be discontinued anyway, because they start at 3 and then they're pushed into school like they're doing a PhD. They have to right away start, so there's no role for over minus glasses. That number 2, if there is a strong family history of myopia, an older sibling, their parents were myopic from a young age, the parents' siblings are all myopic, do not prescribe over minus glasses.
Thank you, ma'am. Thank you.
Yeah, in Australia the school age is about 6, so it's a very small window, really.
We get them home and put them in school. I actually have a question. I have a question for Dr. Miho Sato. I was curious. I know you said the 6% were cured, 37% improved, and 43% had no change. I was wondering, we do know there's a lot of papers talking about binocular vision anomalies, both convergence and accommodation anomalies, to be responsible for, either some subset of patients being more prone to develop problems, ASE after smartphone use, and also some who do not resolve because of the binocular vision anomalies. Did you think of studying that, or would you be studying that?
Yes, thank you for the question. Actually, in our study, the patient, we included the patient who had the amblyopia or who used to be strabismus, but developed to the larger angle esotropia acutely or in adult age. So the background of the patient have a poor binocularity. Yeah, I believe so. And in addition, some people who did not use digital devices a lot, those patients may have more anisometropia. And so those patients may be looking at the digital devices monocularly. They do not notice diplopia at distance. Mostly they can fuse in up close, but they cannot fuse distance. It takes longer time to notice their diplopia.
Okay. Thank you.
Thank you.
Any other questions or comments from the audience? Yes, Frank. And in the meantime, could we also ask the audience if they have any comments from Singapore? We had 3 cases, all were neuro-ophthalmology, all presented with symptoms which really didn't raise red flags to begin with. So if there's any tips or tricks in the audience, y'all can share with us on how to pick up these neuro cases. Yes, thanks.
Thank you, Sonal. Suba, do you think there's any place for multifocals being in accommodative esotropia?
So I personally don't give multifocals, but I think there's some of my colleagues in Australia I know do use multifocals in slightly older kids in accommodative esotropia. I generally prefer the bifocals with a large near segment because I find these children find it hard to accommodate through different phases of the multifocals. I don't know whether anyone else got different opinion on this.
I do use progressives. Sometimes it's just hard to get the bifocal segment correct.
Exactly.
We don't have many optometrists who would do bifocals, or even if we do,
very
the parents
true.
come back saying, oh, they're not available. So
Yes, very true. So what I tell them is bifocals with a bigger near ad with the inverted D segment. That gives a slightly wider near segment. But yeah, I think progressive can be tried in older children when they don't like the look of these glasses with the line. I think there's some role in older children, but I personally haven't really done that many multifocals.
Thank you. I have a question for Dr. Wang, actually. So, and this may sound like a parent asking a question. So we have these intermittent exotropias who are myopic, okay? And of the several mechanisms of control of why there is better near control, we know that high AC by A ratio is one of them. So I've always wondered, this constant accommodation, is that to control the intermittent XD, is that making them progress in myopia? In other words, should we be really operating on these intermittent XDs early as a way to prevent myopia progression? You know what I'm asking?
Yeah, and I think intermittent accommodation and associated with convergence may have a more load or work for these muscles, and maybe that would be one of the reasons you suspect that could be the reason for progression of the intermittent exotropia. And that also raises another question, is that should we give the atropine eye drops to these patient regularly or intermittently? Should we block all the accommodation power for these patients, and so that they may not progress at all? Actually, I have no answer for that question. And also, for the intermittent exotropia, we often observe their symptom or their degree of exotropia progress as they grew up. And however, some of them has been associated with myopia, some of them are not. So personally, I would use the atropine eye drops intermittently. I don't try to block all the accommodation power by them, and I don't think that would be physiologic for them. However, in that condition, I cannot stop the progression for their exotropia. So we just go by clinical practice that if the deviation angle is going very worse, and also the condition becoming a constant exotropia, we will put them on the surgery. However, I think to operate it earlier, does that stop the progression? I don't think so.
You don't think that would make a case? Okay, thank you.
If any other questions, I'm going to, yes?
About operating early. I know traditionally we say deteriorating stereopsis and increasing angle is probably the indication. The challenge now is if they're myope and you're correcting their exotropia and you make them slightly esotropic. One is you're worried about the stereo. Second is the progressive myopia. I think the consequent esotropia becomes a challenge as the myopia progresses. So it's really hard to know how much to correct them. Do we need to overcorrect them or undercorrect them? Maybe it will help with the progressive myopia.
Yeah, thank you.
Thanks. I would have some questions for Professor Angkor Wang. For those of you in the audience who don't know, Professor Angkor Wang, in addition to being a strabismologist, is a world-renowned neuro-ophthalmologist. And he's even an author on a book, on a very excellent book on emergency neuro-ophthalmology published by Springer. So I'm going to now ask him to shed some light on our 3 cases of neuro-ophthalmology which were presented.
I think the case for the cerebral palsy is amazing, that it presents as a ptosis at initial stage, and we know that cerebral palsy is very miraculous palsy, because it can be initially presented as a isolated ptosis or isolated muscle palsy, either the medial rectus, superior rectus, or inferior rectus. Any kind of isolated muscle palsy could be the initial presentation of cerebral palsy. Even I met some patient who was initially presented with an isolated pupil dilatation without ptosis, without extraocular muscle movement palsy. So when you meet all these kind of patients, do remember to check the blood tests you should be doing, such as anti-acetylcholine receptor antibody, and at the same time also remember to follow them. Usually the cerebral palsy will progress, so at the follow-up you will see other signs, and then you will be alerted and then go on for imaging study. That would be important part for this. And for the internuclear ophthalmoplegia, and that would be some place between the midbrain and the pons. That's the MLF located. And usually, if you suspect in some case of exotropia and with a limitation of adduction, do look at the other eye to look for the abducting nystagmus. And also remember to check after correcting the exotropia. Remember to check if there is hypertropia or hypotropia. Sometimes skew deviation is associated with this internal nuclear ophthalmoplegia. If you found there's some vertical deviation, you should be careful. That could be not a simple exotropia. That would be what I can comment on these cases. Thank you.
Thank you so much. So the lady actually with the long eyelashes, she was my patient. I nearly missed her case. So she came for follow-up to my general clinic, and she said, oh, my lid lesion is settled, everything's okay. I had never seen her with the long lashes before, and she was a contact lens wearer. So she had this mild ptosis. Now many contact lens wearers have a slight ptosis. I checked her lids. I was about to send her home. She got off from her seat. She went to the door. She was about to go out, and she turned back and she said, but you know, actually I've been having some difficulty in reading. When she turned back and looked at me, suddenly the exo decompensated. And that's when I saw the exo. And I said, oh, why don't you just come back and sit down? And that's how the whole story opened up. I would have missed it. I was about, she had already got off from the seat to leave the clinic. I had even signed her out in the system. And then she said, oh, by the way, but I'm not reading very well. And then I looked back at her and I saw that small exo. And that's so. It was a total near miss. She was about to walk out of my clinic and she probably would have collapsed in the next few weeks because the aneurysm may have ruptured. So yeah, thank you.
Yeah, that would be very lucky to mention about she couldn't reading very well because of a small deviation of the XT. And also, usually in a mild ptosis, we will recommend to check the pupil at the initial encounter. If there's a dilatation, suspect cerebral palsy. If there's meiosis, suspect the Horner syndrome.
Thank you so much. It's very valid tips, but you know, when you are in a general clinic with 10, 20, 30 patients waiting out at your door, sometimes this may just slip out of your fingers. So that's a very good learning point. Thank you so much. Any other comments from the audience?
I wanted to make a comment about an extension of Dr. Subhashini's talk. So after 20 years of being pampered by optometrist in an institution, I found myself in private practice where I do my own retinoscopies. So these two learning points are from that. So one is very common in India for the optician to decide to give myopia control spectacles. You may not have written them, but they will give the spectacles. So, and I don't have my own optician. So I'm at the mercy of the optician outside. And they will prescribe it for any myope. When an intermittent XT decompensate, the myopia control spectacles are of no use. So you have either you operate, fix the XT and then give, or tell the patients to please change the optician. So do not, be very wary when your intermittent XT easily decompensating patient comes back with, whatever they are, the myopia control spectacles. The second is refracting the myope, because we are always used to using cyclopentolate in the clinic or a dark iris, and when you ask them to look at a distance target, the XT decompensates, and so you're trying to find the center by swishing up and down, and the next second they're looking at you, then they're again looking at the distance, and so it's a battle to try to refract a myope who had an intermittent XT with myopia, who is poorly who's easily decompensating. In these, atropine is a big boon. So if you want accuracy, don't hesitate to do an atropine refraction, because we think of atropine refraction only for hypermetropes and esotropia, but they are invaluable for intermittent XTs as well, especially if you are doing the refractions. Thank you. Okay.
Thank you. If no other questions, oh yes, please.
Good evening, ma'am. I just want to ask that you have just told that in myopia also you can do the cyclorefraction. Generally, I have seen that in myopia it doesn't change too much, but still I just want to know that till what age you will prescribe cycloplegic refraction for the myopia.
So,
because in current practice, when you have so many people and so many kids coming out,
right.
and if you're making them dilatation
Right.
sitting, then 1 hour.
Yeah, I'll only speak from what the national guidelines, generally accepted guidelines. So what is recommended to follow a myope who is, you're monitoring for myopia progression, is an automated cycloplegic autorefraction, not even your own refraction, because that way you ensure that there is objectivity. So you follow them with two things. One is cycloplegic autorefraction, and in our population, ideally cyclopentylate, okay, and the axial length measurement with the non-contact biometry. That's how we, yeah. So answering your question, I would often, till even well into their teenage years, would do a cycloplegic refraction if they are on myopia progression treatment.
Yaolin, you want to answer this? You can come on the mic here.
The low dose atropine, not controlled with low dose atropine. Basically, if do you ask for the children with XT or just normal myopic children? If the children with both XT and myopia, I would prefer, because based on my presentation, I have a concern for high dose atropine if they have decompensated XT. So I would prefer to shift to contact lens like Ortho K or multifocal soft contact lens, and now we have choices for myopia control spectacles. So I have preferred to choose this kind of treatment because this will correct the refractive error and don't disturb his baseline accommodation. And so I've shifted to optical treatment. But sometimes I hope to achieve a better myopia control because we have long-term follow-up, and I can see most of the children they still progress. So if they have a fair XT control, I will try high dose atropine because high dose atropine is still the most effective treatment for myopia control. Thank you. Yeah.
Thank you, Yaolin, for the perspective from Taiwan. Do we have Jason in the audience? I think I saw him. Jason, I think everyone knows Jason. He's a Asia Pacific leader in myopia. So Jason, would you like to give comments to our colleague's question on defocus spectacles?
Nobody can escape Sonal.
So do you want to repeat your question again for Jason?
So I think nowadays there's many other options. For low content atropine, we can increase the dosage. If it cannot, and then I will switch to red light therapy. Red light atropine 0.05% can reduce 70% efficacy. For red light therapy, can reduce up to 90%. And we are now doing some more combination therapy that can hopefully can achieve more complete control. But there's still emerging field. I would say evidence evolving very fast, and I look forward to having more information and data to share with you later on. But there is definitely more and more options that could be available. Thank you.
So that was a brilliant session. I'm sure you will agree. So I'm sure a lot of you have questions lurking, and please do continue the discussions outside the hall as well. And we thank you immensely for participating, for attending, for staying with us. And I thank our co-chairs, Dr. Sonal Farzawandi and Dr. Wang. Thank you so much.
Can we have all the speakers to come in front to take a group photo, please?
Dr. Meenakshi, you remember? Dr. Sunil from
Yes.
You have to come to Varanasi.
Yes, sir.
बहुत दिन हो गया Alan has come, everybody has come. Sudhir also came.
बुलाइए तो आएंगे हम.
हाँ जरूर.
Thank you so much.